I will want you to know. I've been more inclusive in the handout, but in the table and in the objectives when I write them, I'll decide as I go through. So won't overwhelm you with them, but the ones that are very notable, especially like clozapine and its side effects, are very dangerous and need to be kept in mind. So the two other cardiac, the myositis and cardiomyopathy can occur more commonly with clozapine. It's rare, not very common. I'll say a little bit more about it because I've got one section just on clozapine. Orthostatic hypotension, much more common. You have effects on the alpha-adrenergic blockade. So when they stand up, they can't clamp down and vasoconstrict, so it takes their body a little bit longer to regulate, so they tend to get lightheaded and they can faint. So orthostatic hypotension is common with all of them. They usually will go away. They'll usually adjust over time. But we warn them about changing positions quickly. Benign, self-limiting. Dividing up the dose sometimes helps. I've given you other things down there. Slowing the rate of dose titration, so it's going to happen when you first start it and when you increase the dose each time. Blood pressure and heart rate monitoring need to be part of your regular. Most of the time, if you're a primary care, you're already going to be doing it. You're going to weigh them. You're going to get their blood pressure and heart rate anyway. So that becomes part of your monitoring parameters, not only for the health of the patient, but also for the drug, these drugs. On the top of page 8, these drugs increase the risk of mortality. So much, significantly enough, that in 2005, the FDA required a black box warning that states that it's about a 1.5 to almost 2 times the risk of the general population or those not using it increase in mortality. More commonly in the elderly. First was seen when they started using these drugs to treat dementia. In elderly, the risk of death went up quite a bit. Not really know why it doesn't. It's thought that a lot of the deaths are cardiovascular. That's why there's this shift in emphasis on making sure that patients are monitored and cardiovascular risk addressed. So that's why that's becoming important. You see also stroke, pulmonary disease, cancer, diabetes as part of it. So it's one of those drugs where the benefit is high, the risk is high. So that trying to balance those is difficult. If this drug was used, if this class of drugs was intended for another disease, they would probably get rid of it. But you've got a disease where you don't have a lot of really beneficial pharmacotherapy. You don't have a lot that you can choose from. So we're going to tolerate a lot of the risks, but it behooves us to monitor for it and ameliorate it as much as we can with lifestyle or other medication or other treatment. The second generations are a little bit lower than the first generations, and also is why they're a little bit more popular as well. Okay. Sexual side effects. So just like we talked with the antidepressant, this class, both the first and second generation, have a high risk of sexual dysfunction. It goes in hand with its effects on prolactin. So when you decrease, or when you sit on those dopamine receptors, you take the inhibition off of prolactin production. So prolactin levels often will go up when you're using these drugs. So how are patients going to manifest that? What's hyperprolactinemia symptoms? Galactorrhea? Menstrual disturbances? Oh, visual, sorry. Menstrual disturbances are in there. It's in there. These are listed in your handout. Breast development in men, so gynecomastia would also be a side effect. So when you see sexual dysfunction, also check the prolactin levels. I've got a list down there of all the agents. You'll see that most of them have a significant 50% or greater complaints. You see that aripiprazole has a lower, so it might be one to consider moving to or starting with, depending on the patient's presentation. Also asking, assessing, making sure that you're aware and patients know to report it. Evaluating prolactin, standard treatments for sexual dysfunction can be employed here. Medications that are used otherwise can also be used. The biggest thing is knowing it, or being aware of it, educating patients, monitoring for it, and addressing it. Prolactin we've talked about. Risperidone is really a huge offender in this group, and the increase in pituitary adenomas is much higher with that drug compared to others. So keeping it in mind, you may even want to monitor prolactin levels in patients who are particularly on risperidone. Any questions or comments about those two sections? Anticholinergic, sedations, falls are going to kind of be, we're going to wrap those together. So these drugs are work on histamine and muscarinic receptors. So their anticholinergic effects are high. Mostly it's dry mouth constipation. Urinary retention, blurred vision, not as much. The one that stands out though is clozapine. You get a sialuria, so increased salivation instead of dry mouth with that drug. No special monitoring is really required. I think asking and addressing. Constipation really needs to be addressed with these folks because they can be so severe that they can get fecal impactions. So it's important to address bowel health and how to prevent. Through diet or exercise, water, or using medications to treat the constipation is important. The sedation can be significant. So warning patients early on that these drugs are real sedative. You do build a tolerance to them pretty quickly, but if they're involved in heavy machinery or operating something that needs to be full attention, warn them when you increase the dose, change the dose, you can see that reappear. Doesn't really take any other intervention. It's mostly warning them and realizing the tolerance usually builds fairly quickly. Falls. So this year the FDA came out and said that antipsychotics increase the risk of falls and also fractures. So their recommendation is that a fall risk assessment be performed before these drugs are started. Neuroleptic malignant syndrome. If you look on the next page, I put the chart that I used with serotonin syndrome back in here so that you can see. It's under the very top, neuroleptic malignant syndrome. So again, increases in muscle tone, hyperthermia is a problem. This is a medical emergency. It needs to be addressed. High fatality rate with it if it is not recognized and treated. A little bit different presentation. Pupils normal, bowel sounds are normal, reflexes are low. So a little bit different presentation. Recognizing it and treating it promptly, most patients will recover. The one thing they recommend is that you always screen patients. If you're seeing somebody for the first time or you're starting them on a new agent or switching them, is to screen for previous episodes. So one of the risk factors is if you've had this before, you're likely to have it again. So that's the recommendation for this one. The other would be other risk factors that they recommend are aggressive dosing, parenteral use of drugs versus oral. If they have acute medical illness on top of their disease, or stresses, dehydration. Those are the big risk factors. We're decreasing now in incidence of side effects. Seizures, all of the drugs in this class will carry a warning about seizures. These drugs don't tend to precipitate new onset seizures. They tend to change seizure threshold, and so the patient may have more frequent seizures. Even though it's still a fairly rare occurrence, they all carry that warning in their package inserts. Clozapine tends to, and risperidone tend to be the higher drugs in this class. It's recommended on that last bullet, if clozapine has to be used, then they recommend that it be used in consultation with a neurologist regarding how to deal with the seizures. Cataracts, rare. The recommendations are twofold. One for quetiapine, even though it is a low incidence, the recommendation in their package insert is that they have a slit lamp exam after drug is started and then every 6 months thereafter. The rest of them, they recommend ocular examinations every 2 years in young patients, and then those over 40 every year, which is kind of a general recommendation. Low risk with other drugs other than quetiapine. Agranulocytosis. I'm just going to say a few words about it, and then I'm going to talk about it more in detail under clozapine. So all of these drugs can have, it's rare that you can get an agranulocytosis. There's a couple of them, Clozaril, clozapine, and what's the other one? Risperidone are probably the higher in this category. With clozapine, there are criteria that you have to follow if you're going to use the drug, and I'll address that in just a few minutes. The last, the hypersensitivity syndrome. Like, this is another one of those, if you're going to be on, do you want to be a millionaire? And they ask you the most common, besides GI side effects of a drug, pick allergic. Almost any drug can cause an allergy. But some drugs can cause very idiosyncratic, very serious hypersensitivity syndromes. And with, it's like trazodone. This one can cause what's called DRESS syndrome. Have they talked about that at all? Have you heard that one? So it stands for drug reaction with eosinophilia and systemic symptoms. It occurs, there's a delayed response. It occurs usually in the first 8 weeks of therapy with this drug. They get a fever, a rash, a lymphadenopathy, and eosinophilia. It has a mortality rate of 10%, which is pretty high. So it's one of those odd reactions, but it can be severe. It's mostly treatment is supportive and use of steroids till the response resolves. Okay, so that's the second generation. I want to talk about clozapine just specifically because it has some regulations that if you're going to use it, you'll be aware of because you can't prescribe the drug unless you meet them. So neutropenia is the major problem with clozapine. It is so life-threatening that the United States has criteria for use. If you are going to use clozapine, you have to be accredited to do that. If you're a pharmacy to dispense it, you have to also be licensed to do that. And in the pharmacy, if the blood in the lab, they kind of made them the policemen. If the lab isn't done, can't get the drug. So no blood, no drug. I think I gave you that little phrase. So there's a registry for patients that are on clozapine, and there is an absolute neutrophil count. You have to have a minimum of at least 1,500 per microliter to be able to initiate the drug. Let's see, if you go down. So patients have to get weekly to monthly monitoring of their blood. And they have to maintain that level, absolute neutrophil count of 1,500 or greater. Lower requires more frequent monitoring, possible a stopping of the Clozaril until a recovery. History of having neutropenia to other drugs or having it be again or in the past due to Clozaril puts you at higher risk. And it can occur very quickly once the drug is restarted or rechallenged. So keep that one in mind. What did you talk about Clozaril? So where does it usually fit? Do we use it first line? No. When do we usually use it? What kind of drugs? It can be used if there are significant side effects to other drugs, but it's usually used in treatment resistant if they have not responded to the usual first line or they have a contraindication. Then clozapine it's a very effective drug, but it can carry some significant side effects of its own. Okay, so that's the second generation. So let's look at the first generations. Most of this will be the very same. So you can learn them all as one and then just remember where they stand out over the other or have exceptions. With the first generation, you don't see the metabolic. You don't see it as much. It's more rare. You still can see weight gain, but diabetes isn't, or hyperglycemia is not as high. You can see some elevations in blood pressure. It's not as great as an extent as you see with the second generation. Under cardiovascular, though, much different. So the problem with this first generation is the QT prolongation. Sudden death has been reported. Highest risk is thyroidazine, the old drug Mellaril. So much so, the risk is so high with this drug is that it's not recommended for first line. If you were going to use a first generation, it would not be one of the ones you would use first. The other is IV Haldol or haloperidol, which you might use in an acute crisis situation. And the other would be Pemazide. Pemazide is a problem when you're using it in conjunction with a 3A4 inhibitor. So what are the really strong 3A4 inhibitors that can also prolong QT interval? Oh, you ought to have the macrolides emblazoned on your brain. So the macrolides are the big ones. Remember, clarithromycin, QTc prolongation. So keep that one in mind. Ondansetron would be another. The azole antifungals, verapamil, very, very common. Baseline prior to prescribing, so this is for the first generations, an EKG, at least annually. Check it during dose adjustments or if the patient's cardiac status changes. Serum potassium levels, why is that important? What did we learn about low potassium and cardiac? Puts you at risk for arrhythmias, particularly the malignant arrhythmias. So for QTc intervals, don't start the drug if the QTc, the interval is 450 milliseconds or greater. If during treatment it goes above 500 or changes more than 60 milliseconds, it can be a harbinger for torsades. It merits either changing them to a lower risk drug or discontinuing and changing to a lower risk drug. Avoid the 2D6s. Remember we talked about that one on Tuesday, and the fact that a lot of the cardiovascular drugs are metabolized by that subset of enzymes in the P450 system. For other first generations, they're much less, monitor those patients who are at higher risk for cardiovascular disease with your EKG or potassium. Questions about those? So that's a difference. That's a difference between first and second generation. Orthostatic hypotension, pretty much the same. They have alpha adrenergic blockade, so it's very similar with this class as well. On the next page, page 13, increase in mortality. It's the same thing we heard with the second generations, except you have a little bit higher risk with the first generation compared to the second. Under sexual dysfunction, it's the very same. All that class is a problem. Haldol is probably the highest in that group. Same with prolactin. They all elevate prolactin levels. If you have sexual dysfunction, check the prolactin level. Ask about it, monitor for it, anticipate it. Anticholinergics, same thing. These drugs also have effects on muscarinic receptors, so you see increase in dry mouth constipation being two of the more common. Sedation, the same, highly sedating. In fact, we use that side effect to sedate people. So using the old phenothiazines as a sedative or a major sedative is common. Falls, the same thing. The same warning goes with the first generations as it did with the second generation. Because you've got that hypotension, you've got the sedation, particularly in the elderly. Next page, 14, neuroleptic malignant syndrome, same as we saw with the first generation, the second generation. Seizures, it's the same story. It will lower seizure threshold, doesn't cause new onset seizures usually. All of them carry a warning in their package insert about increase in seizure risk. The eyes are different. So the ocular side effects are different with the first generation versus the second. So this pigmentary retinopathy is a common one. I've given you a picture of it. On the left is on the right is a normal retinal scan. On the left is the effects of these pigment depositions within the eye. Other issues are listed there at the bottom, can cause a whole host of problems. Cataracts, early cataracts, epithelial keratopathies, mydriasis, meiosis, you see both of them. Photophobia, accommodation problems, so their ability to adjust, to go from far distance to near distance. Worsening of narrow angle glaucoma. The second generations also carry that risk. All of them do because they have anticholinergic effects. So the phenothiazines, the older drugs, the phenothiazines are the ones I've listed out. They all end in zine. So chloropropazine, fluphenazine, perfenazine, thioridazine, trifluperazine. Some of the older agents. Page 15. Agranulocytosis, again, is a rare side effect, but can occur with these. Again, it's if patients have had it on another drug or they've had it with a drug, then they're more likely to get it again. In general, they recommend that there be a white blood cell count and absolute neutrophil count at baseline, and then early in therapy, follow it up, and then on a more routine, like every 6 to 12 months thereafter. In terms of the liver, chlorpromazine can cause a cholestatic jaundice. It's the most significant in that class, but they will all carry a recommendation from the manufacturer to monitor liver function tests. Questions? Comments? Okay, so we're going to look at EPS now and look at two different kinds. We're going to talk about first the akathisias, the Parkinsonism, and dystonias. I have some videos to show you. So the akathisias, I'll show you a picture of one, or get a video of one of them. It's just a restlessness. They cannot sit still. They pace. They move around a lot. This can be treated with a short-acting benzodiazepine like lorazepam or a beta blocker, may help if it's bothersome to the patient. The Parkinsonism we're going to treat a little bit differently. We're not going to use levodopa or a dopamine agonist. It'll interfere with the treatment that you're using to treat their schizophrenia. So we use like benztropine or amantadine, which were lesser drugs that we mentioned for Parkinsonism, can be used to, if it's uncomfortable for the patient or is causing them significant disability. The other would be to reduce the dose of the antipsychotic. On the top of the next page, the dystonias are involuntary contractions of major muscle groups. I've got some pictures of them on the bottom. On the left-hand side, that woman has torticollis. The man in the middle has retrocollis, and the young girl there has ocular gyrate crisis. And then the orange picture is the opisthotonus, or the picture below. So several of you all have told me about having torticollis due to drugs. I think Amy talked about her husband having it. Dr. Britton had it one time. You want to tell them? I gave them some description, but you want to tell them about how it felt from your standpoint?
I think I did, didn't I tell you?
Did y'all tell them? He looks so weird. It's like,
I was afraid she was going to drive me to the ER.
Oh, he was.
I was.
we were more younger married then. It was more likely. Now I might just throw him Benadryl. Anybody, someone else, who else told me about it?
I will tell you, it's scary. The biggest thing is that you know something is not right and you're not quite sure what it is. Then when you begin to be aware that it's probably a drug thing, it actually is pretty scary and you cannot control yourself. And that's what's so scary about it, is that you can just feel it coming on the wave and your body's doing something like stop, and you can't do it. And if it really starts to get your muscles for breathing. I was having shortness of breath. I couldn't get a deep breath, and I could not go down because when the wave would come over, it would just almost constrict you. And so it's like we go to the ER. Something bad's happening here.
You want to say anything about your...
No, that's exactly how it was, and it was after the same drug, too.
Compazine?
Yeah.
Compazine, so that was terrible.
One dose.
And the last dose is all I've done.
Yeah.
Let's see. I have seen that opisthotonus one time. It is such a painful. I even looked at some pictures or videos online, and I just couldn't bring them in. They're mostly of kids. They are very distressing, I think, to watch because they're so total body, and they are. The pictures they have on the internet, the people appear to be in pain when they are going through it. Okay. Okay, now this one looks like I know I added it as a, okay. So do I have to do the same thing? Let's hope I can.
On? Okay. What side?
This guy's having
This is the camera side?
gyrate
Oh, where's
crisis.
the one? Okay. Am I doing my face all right?
It's
Which way? This way?
yeah, you're on your face.
He can't see
Okay.
because his eyes won't cooperate.
Yeah, I just want to get a video of how this is supposed to work.
Yeah.
This is driving me crazy. Okay. All right, go on and stop it.
Oh, this little boy has it too.
Look at me, show me your eyes. This time, I just need to try, I want to video it, Jake, look at me. Look at me.
Let's see. This one is in are. So they do a lot of them.
So, when did you start having trouble talking? Early this morning? And did you take any drugs? Other than your prescribed drugs? No? You don't do cocaine or anything like that? No? Okay. Count to 10 for me.
1, 2, 4, 5.
Okay, that's good.
Okay, so they showed you Benadryl, I'm showing you Benstropin, so you're going to use an antihistamine to get them, most of them, to get the symptoms. Yeah. You'll see you can see them with either one of the generations. The first generation are a little bit more likely to cause them. The more high potency drugs, and in the chart that I've given you in the handout, it shows you the high versus the low. Most of the first generation are considered high potency. So when you're evaluating them, asking them about these kinds of episodes in between is important, and also to modify the dose or move them to less likely agents may be helpful. Tardive dyskinesias, have you all talked about those or seen pictures of them? Did he show you videos? Yes? No? I can't get a sense. Yes.
We did some.
So did you do what? The lip smacking or the
We did the lip smacking. I
Okay.
think I made a picture. I don't know if it's a video. It's disturbing.
I find them disturbing. I feel so bad for these folks because they're,
I remember seeing them growing up when I was little, and I
did
wonder what's
too.
wrong with that person, and you kind of, they kind of creep you out. And then now that I know what they are, I feel like I was kind of cruel.
What I did, because it did this as a hyperlink, so I don't know when I did something I should have.
In the second segment, notice this patient's blinking.
What they're doing is they are using those that scale to grade the level of their abnormal movement. There's a scale you can use called AIMS. And so a lot of what, I'm not so worried that you listen to that, but just watch the patients. I'll kind of move through the video so you can see it.
Try not to be distracted by the other facial movements.
Watch her mouth, her eyes.
Notice the blinking takes place during the finger tapping exercise. This is one of the activated movements. The 1-point score reduction used by some examiners is not recommended. The score on
This lady's is very
features
subtle.
a rather subtle lip movement. Notice the sucking in lower lip.
Very subtle.
In this segment,
Watch her mouth. We're grazing.
segment 5 shows obvious perioral movements. This man's movement disorder also involves the neck muscles, which should be scored on section 7 of the examination. For now, focus on just the perioral movements. Notice the frequency, also the amplitude.
Oh, his is so slow.
Illustrates a slow chewing movement. The patient in segment 10 has constant jaw movement. Notice the frequency and amplitude of the movement does not change. It is the same before, during, and after the activating exercise of extending the arms. Segment 11 is quite short and will be shown 3 times. Notice the increased frequency and amplitude of this woman's jaw movements compared to the previous segment.
I'll show you what others said. This lady has a dystonia.
Keep your mouth open. Okay, that's fine.
With the choreic disorders, the constant.
She's very aware, but she
Patients
has
either are unaware or underestimate how bad their movement disorders are. Whereas patients with tardive dystonia are very much aware of their syndrome.
Turn sideways. That's right. That's perfect.
Dorothy has these involuntary movements of her arms, particularly her left arm. But the major problem here was the arm and the axial dystonia, so that she's leaning backwards.
Just going by itself, huh? Can you hold your hands up in front of you? Both hands.
During this entire time, her psychosis was completely controlled. But they weren't able to find any other medication.
This lady's really sad.
This 76-year-old woman has a 2-year history of tardive orofacial stereotypies related to an 8-year treatment of chronic nausea with phenothiazine.
She didn't have schizophrenia.
How old are you?
77.
And what is it that's bothering you the most?
My mouth.
How long have you had problems with your mouth?
Well, I guess about a year and a half.
How long?
About a year and a half.
Okay.
So they are disturbing to watch. The only way to prevent them is not to use the drugs. That is why the second generation have become more popular, is because they're less likely to do this. The first generation are much more associated with them. If you look on page, let's see. Let me just kind of sum up what's on those 2 pages. I got redundant on a couple of things. So monitoring, there is a scale, and if you haven't been given it yet, I'll post it. It's an abnormal involuntary movement scale, which they were showing you in one of the videos, and I can post that so you have a copy of it. So using the least likely drug that will cause tardive dyskinesias, monitoring for it, being able to modify the dose or taking patients off are your options. So there aren't a lot, but we do have lower risks now with these newer agents. Assessing, it's hard to prevent them. Clozapine has one of the least likelihood of producing, so that's one to take into account. Page 18, there's a few drugs that can be used to try to lower the risk. Benzodiazepines have been used for very focal areas. You can use botulinum. or you can use a drug called tetrabenazine, which is a drug that just knocks out a lot of the neurotransmitters. But it has its own problems, but it's a very powerful drug. We don't tend to use the anticholinergics as much because they aggravate symptoms, and they're just not as good as some of these other agents. Dr. Burton, you want to say anything else about tardive dyskinesias?
No, not really. We talked a little bit about the fact that some of the older agents, if you got it, tardive dyskinesia, it could be permanent. Now, I think that was the problem, and that's why those second generation agents have come along, is they don't land and dance on that dopamine receptor so much so that you don't get it. So, and that's their big virtue, I think, is that. What I found interesting is in the VA, they are still looking at those older line agents. Well, because it's a financial issue. So you can't just quickly go to a second generation agent in that system because they're all fairly expensive. So they're looking at Haldol and some of the older ones. They're looking at Prolix and Haldol, which are high potency agents before they move over. So they still have criteria to get the more expensive drugs. But that's kind of that's the system.
Yeah, but most of these will be going on to generic soon, because Clostrill's been on for since 2002. So.
That'll revolutionize things, and I think if you look at the healthcare system in Oklahoma right now, Medicaid has a lot of people who have mental disorders, and they will blow a budget up. These second generation antipsychotics, we're not talking about $15 and $20, like hundreds of dollars a month. And so if you have a large number of psychiatric patients at hand, they can blow a budget, and that's why they put criteria on them, and they have tiered approaches to get to it. And that'll be the one thing that'll drive you crazy in practice, is you can't just go a certain direction. You have to try things and, kind of work your way up to it. So tardive dyskinesia is terrible.
It's terrible. But I played that one because I want you to keep in mind, it just in the psych drugs. It's using them, like for that lady who had chronic nausea. Also metoclopramide that we use for as a like for gastroparesis can also do the same thing. So it isn't just this. So you have to kind of keep that in mind for those more focused areas. Okay, I will probably get the table in. I've had questions on the objectives. I'll specify, since I've given you several different sets, how to do that, or which ones I'm using, and then I'll see you on Tuesday.